Hey everyone, welcome to the Titans of Healthcare podcast. I'm your host, Jared Taylor. Today we're talking about a really cool topic, food as medicine. And it's been really a topic that I've been super interested in for a long time. And it's been crazy to kind of see how it's been impacting now even events. There's food as medicine sections at the health conference, and there's even standalone events recently. And I'm really excited to be joined by we have Brian and Lauren, and I'll let them say name, title, and backgrounds real quick. But for this conversation, so let's first kick it over to Brian. Brian, tell everyone about you, and then we'll dive in.
Yeah, hi, I'm Brian Jones. I'm a dietitian by training and background, currently working for AssureCare health technology company, supporting some of their various products. I've also have a background in case management and care management from the payer side, so bring kind of a dual roles to this food as medicine conversation. I'm glad to be here. Thanks for having me.
And now, Lauren.
Hello, I am Lauren Barca, a public health nurse, background in government space, payer space, vendor space, really passionate about food as medicine, and it's a pleasure to be here. I currently am the VP of Quality at 86 Borders, a care coordination organization dedicated to helping people remove the barriers to care.
Love it. Thank you both for the intros. Let's dive right in. Lauren, we'll stay on you for a second, and then we'll kind of go back and forth throughout the conversation. But kind of give us an update on food as medicine, and what's adoption looking like across the space. What are you seeing?
There's a lot of bills that are being passed really across the country. We've seen it for several years now from CMS. Really in the SSBCI space from a Medicare Advantage is where it started, that supplemental benefits space in Medicare Advantage. And then it's really growing into the Medicaid space. As we know, the New York Medicaid program recently enacted the ability for Medicaid managed care to allow it to be part of their benefits. So we're starting to see it roll out in the Medicaid space as well. I think it's really exciting to see it grow and expand, to see how Medicare and Medicaid are looking at it from both the same and the different lens. Really from a benefit structure perspective is where I'm seeing the largest growth from a policy standpoint right now.
And Brian, anything you wanted to add in terms of what you're seeing as well?
Yeah, I think that was a great place to start, and definitely in the Med Advantage population, seeing those initial, the coining of that phrase and more emphasis around it after the White House conference. Man, it's been over a year ago now since we heard about that. I think that we're hearing a lot of it from the industry as well, and the term food as medicine is being used in many different facets, from even the pay scale for food service employees, all the way through these initiatives where we're providing meals and services to address social determinants issue with our, end clients and patients.
And Brian, we'll stay on you. What are some of the challenges that we're still facing in this space?
I think that the definition of the interventions and monitoring outcomes is something that I don't know if it's really a challenge right now, but it's something we need to keep an eye on as this matures. So those first few initiatives that were put into place, like the medically tailored meals and home delivered meals with our Med Advantage population, that was a great first intervention. We saw it lower the amount of hospital readmissions. But why was that? Was it because they received food, or was it because of the unique nutrient profile of those meals? I think that we have to parse out some of the interventions and where we best invest our time, money, and research.
And Lauren, anything you want to add in terms of what challenges we continue to see?
We have seen a lot of innovation to date, which is exciting, and it's a new space for Medicare Advantage and Medicaid. Even providers and health systems getting involved. We've seen lots of innovation. What do we give? When do we give it? Are we doing medically tailored meals? Are we doing farm boxes? Are we doing, one-off just home delivered meal kits, etc. um, it's been a little bit frenetic from a member or patient perspective. Am I getting one meal? Am I getting ongoing meals? Am I getting an ongoing relationship with the dietitian? And so I think a real challenge has been from a member or a patient perspective. And I think moving forward, there's going to have to be better coordination. To Brian's point, we've got to figure out what is actually then what's moving the needle there. What can we actually quantify there as making a difference? There needs to certainly be better coordination without losing that innovation. I think there has to really be a stop to those one-off offerings. It may have an initial boost in that member satisfaction or patient satisfaction, but ultimately that's not sustainable to prove out an ROI from a payer or policy perspective. So I think those are some of the challenges from both a food need, a human need, that's not going to solve hunger. And then from a payer need, that's not going to solve the end outcome that we're looking for of did that make the difference in improving ROI or improving health outcomes.
It gets a little frustrating though, doesn't it? Where, I mean, there's still a lot of work to be done in terms of, it seems like when you go to the doctor and, there's some sort of health complication, they immediately turn to what can be prescribed versus in many cases food as medicine, or even big fan of also fitness as medicine would be maybe the best solution with less complications, right? Because we've all had that relative or one of us where they start taking medication, and sometimes medication is the best path, but typically there's always that, you take, I had a relative that had heart issues, so the heart medication attacked the kidneys, and they couldn't get a new kidney because they had everything kind of has an effect no matter what you end up doing. But when it comes to food as medicine, that seems to be less likely that if you're eating healthier, like it's frustrating for me when I kind of hear that on the insurance company side of things, there's still certain barriers that need to be reached for food as medicine to be, more front and center. Like I know they need to see outcomes and things like that, but I think for the general population, people get frustrated that, you know, I understand that there needs to be outcomes, and it's obvious if you eat healthier, you're going to be in a better place health wise. What kind of frustrations do you think? Let's kind of look 2 years out. We'll kick it over to Brian, then we'll kick it back to Lauren. What do you think in terms of barriers are we going to potentially get past over the next 2 years? Let's say.
So I want to go back to something you mentioned,
Okay.
and then it's a great kickoff point. I think that even the term food as medicine, there is still some rub about what that means, especially coming from a dietetics background like I have. We've always been around to provide what we call medical nutrition therapy, which is a targeted intervention that is covered by many insurance. But does it encompass the whole gambit of things? No, we're covered for very limited services for very limited amounts of time. So yes, your doctor can tell you, eat better, do this thing, and they hand you that little handout and you go home. Is that supporting really the whole need, both education and the, maybe even learning how to buy the foods, or getting the foods into your home? What I love about food as medicine is we are looking at it more inclusively. The negative to that is I don't feel like food as medicine is replacing traditional medical care, but it's more front and center in supplementing those proven interventions. I mean, we have to have a evidence-based practice on both sides of the gambit there. And I'm glad that we're getting the attention now through this kind of header of food as medicine. So I think in the next 2 years, we do need to determine the goals of each level of that. I've seen this really nice, and maybe we can link the infographic of where the bottom of the pyramid is policy and public awareness, and then the next is public benefits like SNAP and WIC and things like that. Then we move on up to medically tailored meals and guided spend cards and things like that. And along all that continuum is the need for nutrition education and support. So how much of that is focused and reimbursed, to be honest, because people aren't going to be able to do this without reimbursement. It needs to be a barrier that's crossed over the next 2 years, because throwing food at people is not going to fix the problem. They also need support and guidance.
Lauren, anything you want to add? Great thoughts, Brian, and thanks for sharing. And also adding that additional definition to food as medicine, because I think a lot of people, right, they kind of bucket a lot of things into that
Yeah.
broad definition, but it can be more refined than that. Lauren?
Yeah, I think really great thoughts, Brian. Not only from registered dietitians, I think there's going to be a need for care coordination in general, even from like lower non-credentialed individuals, care coordinators, community health workers. I think they have a really huge role in this. And in the next 2 years, I see that blooming and expanding as we think about helping individuals find out how to get healthy foods in their own communities, how to have access to healthy foods in their own communities. To Brian's point, throwing food at people is not going to solve the problem. We have to teach people how to have access to cookware, to how to cook, how to even have access to things like their electricity. If they don't have power, then or a refrigerator or a stove, we're talking about basic human needs here that we sometimes take for granted when we're talking about Americans. But if we're talking specifically about Medicare, Medicaid, and the dual eligible, the DSNP population, oftentimes those are barriers that many individuals encounter. And so we have to really be thinking about it from a basic human need perspective. And I think that there's a real need to stop, to slow down and think about, okay, what are the needs of that individual? Where are they? What are their priorities? What is their basic education level from even a cooking or food knowledge standpoint? And then begin to build from there. So reimbursement is a huge piece to that from every level, care coordination, CHW, on up to registered dietitian. And I think that is all going to be part of it as we see a huge growth in this area. One other point, I think we have to really take a holistic approach. I'm sure Brian can jump into this. When we talk about food as medicine, we have to really think about harm reduction. I know so many people love to throw out like water only or no junk food. I also have to, when we're talking about populations who have been in a survival mode, we also have to change the way we talk about food as medicine as a harm reduction and not start talking in extreme words, take extreme measures, etc. Water only to someone who's only ever had soda in their entire life, soda and alcohol is not going to be listening to what their member needs and their member priorities are. Their patient journey is going to be so important as we listen to this.
Lauren is speaking my language, I tell you. I just had a conversation this weekend with just a group of parent friends, and they're from different backgrounds. And I heard it thrown out once again, and this is old information and old school of thought: only shop the perimeter of the grocery store, only buy organic foods. And I had to intervene and say, not everybody's journey can accommodate those, general ideas, and could they be misinterpreted? Bacon is along the exterior of the store. On the interior of the store, there's canned beans and these other nutrient dense foods that we do want to promote. So I think having some along that continuum of care and care coordination, our messaging and initiatives can be refined much more to support anybody from different socioeconomic backgrounds.
I'm just thinking back to Lauren saying, don't throw food at people. And
Yeah.
I'm just thinking we need a video of people getting food thrown at them, right, Lauren? No, I'm just kidding. Like for myself, there was a time I was having like ice cream every single day. And then I went to Lauren's. I went the extreme way, Lauren. I had no sugar at all. I cut myself off one day and I said no. And I was literally like shaking at some point from not having those because I went the extreme route. Then I kind of, took a look at it and said, I still need to get some sort of sugar. You can't just go from lots of sugar to no sugar. So I started getting it through just fruits instead and feeling better about it. But it is, we actually had a while back, the founder of Noom came on the podcast and talked about, you know, they don't they don't kind of put themselves in that weight loss category. Their behavior change is really where they want to reside. And too often, why people don't stick with diets or exercise regimen is because they go to your point, Lauren, the extreme. And you're more likely to build healthier habits when you're saying, okay, I'm going to, I'll start eating a little bit more healthy, right? I'm not going to do water only. Maybe I'm going to do one soda today instead of 4 sodas today. But let me ask you this. Why don't we, like, I know you two are saying that type of stuff. Why does it still feel like food is medicine? We still try to push people to, to the extreme. That's something, I mean, Brian, would love to hear your thoughts and then we can kick it back to Lauren.
Oh, well, I don't have the full answer to that. I think that buzzwords and these extremes, they sell. I mean, when we're selling a lifestyle, big swings and big changes are what people want, and you can make the association with medication. If you need to lower your blood pressure, medication can do it much quicker and more effectively, especially if you're using good practice. However, there are a lot of other things that go along with eating well that might be a little more tedious and long-term that don't show you those quick results. So I think that's why we, in a nutshell, while we hear more about those changes. And I do think your point about Noom's founder discussing, I think technology support, because it can, as an early dietitian, I started in about 17 years ago. We didn't have technology support. We had pen and paper. We wrote out diets for people. We handed them lists. MyFitnessPal and things like that were just emerging. We do have a whole new set of tools to help support people along their journey, more than we ever have before. So I think it's a good time that we're getting the attention with the Food is Medicine movement to help educate people wherever they're at in their journey, using that, those more frequent touch points than we've been able to have in the past.
What's next for Food is Medicine? What do we need to continue to do here?
I think so many health plans are focused on food screening. It has been such a huge push across the nation. I would just caution every health plan that has invested in the food screening piece to this to really think about what you're going to do with that data, how you're going to intervene. I have been hesitant to really promote the concept of food screening without responsible intervention, even with the intervention of just, hey, here's an address to a food bank, really thinking through how that member will get to a food bank. Do they have a vehicle to get there? How will they access services that they need? Really being able to be holistic in our approach to food screening and intervention is going to be key as we move forward in this food as medicine space.
And from your point of view, Brian?
I would have to agree. And I would add that targeted interventions being monitored and evaluated over time is where I think the next steps lie. And having the technology support and big data approach to that's going to drive policy and funding in the future.
Well, I want to thank you both for joining us here today and having this conversation on food as medicine. Let's definitely stay in touch and continue the conversation. But, I feel like, in a short period of time, we still covered a fair amount of, what needs to change, what's currently happening, and really appreciate getting both your point of views on this topic.
Thank you.
Thank you.